Hello, my name is Dr. Barber. I work at Springhill Hospice. I've been asked to do this video to talk you through the admissions process at the hospice. We are a 16-bed specialist palliative care unit that cares for anybody with a life-limiting illness. The patient doesn't have to have a cancer diagnosis. They can be palliative from any condition. The patient must be palliative and know they are palliative, and the patient must consent to be cared for at the hospice. We are not a long stay unit, and our average general length of stay is 12 days. We take 3 categories of patients for referral: discharge to assess patients, symptom management and end-of-life care referrals. Although we did previously take respite patients, we can't offer this service any longer due to high demand for our beds. So how do we admit? We have an admissions MDT meeting each morning at 9 AM and that's where we discuss our waiting lists. So at this point we prioritise admissions for that day based on need and how supported these patients are. For admissions from hospital, we will call the referrer on the ward in order to arrange the admission. Please remember, we need a number that we can contact you on easily. We don't need the patient to wait for TTOs. These can follow on afterwards. If they are needed at all, our admissions coordinator will advise you on this. We need you to book the ambulance promptly, as we have a cut-off time for admissions to arrive. You might ask why there is a cut-off time. The inpatient unit is staffed 24 hours by nursing staff and healthcare assistants, but the medical cover on site is only between 9 to 5, 7 days per week. This is the reason for the cut-off times for admissions, as they need a medical review as part of their admission to the ward. We can only admit a certain number of patients per day due to staffing and occupancy, and this will differ daily. If the patient doesn't arrive in time, then we will have to delay their admission for that day. This doesn't automatically mean they can come the following day. We would reassess the need of the patients on the waiting list and may need to offer the bed the following day to another higher need patient. How long do patients stay at Springhill? We have our discharge to assess patients. They have a maximum stay of 4 weeks. We only have 2 allocated discharge to assess beds. Discharge to assess patients must have an HMR GP in order to be eligible. So discharge to assess, these patients are being referred to the hospice for ongoing discharge planning after being considered to be ready for discharge from the hospital. They must be palliative patients and they need to consent to referral. They're often patients that are awaiting packages of care for discharge home or awaiting nursing home beds locally. These patients should be medically fit for discharge, and discharge planning should be discussed with the patient and the family, as we will continue this process at the hospice. Ideally, there should be a discharge pathway identified. Usually this is home with support or 24-hour care. The hospice discharge to assess beds act as a step down from the acute wards in order for us to continue to facilitate their discharge plans. The maximum time scale for these beds is 4 weeks. The patient and family have access to all hospice resources during this time and will often continue to have support after discharge if they're eligible for referral to our community specialist palliative care team. Unfortunately, we don't accept patients with challenging behaviour. We may question discharge to assess referrals for dementia patients purely due to the fact that moving into different environments can be extremely disruptive for these patients. So an example of a discharge to assess referral would be Albert, an elderly gentleman, multiple recent hospital admissions following a fall at home earlier in the year. The most recent hospital admission is within a community-acquired pneumonia. Over the course of the last few months, he has deteriorated generally and become less mobile and more dependent. He's now unable to go back to his own home as it would be unsafe, and he can't care for himself. Family and patient are considering a nursing home discharge from hospital, and he is referred to the hospice as a discharge to assess patient. On arrival at the hospice, he does improve slightly in condition from some rationalising of his medications, symptom management and some mobility supervision and support. Following further conversations with the family around support available from CHC and the hospice, they feel that home might actually be manageable with equipment and some modifications. Due to the patient likely being in the last 12 months of life, on asking the surprise question, he is referred to our community palliative team and receives specialist follow-up after discharge. Now, symptom management referrals should be made for patients that require specialist symptom support prior to being discharged. Common symptoms we manage include pain, nausea, vomiting, agitation or delirium, side effects of oncological treatments. This list is not exhaustive. We don't currently offer rehabilitation or respite placements. If you are unsure or you want to discuss a complex patient prior to referral, please feel free to contact our medical or nursing team on the ward to discuss this. We're always happy to advise regarding specific situations. An example of a symptom management referral may be Joanna, 48-year-old lady with metastatic breast cancer, admitted to the hospital with breathlessness. A scan revealed lung metastases, and all reversible acute issues like PE and infection have been excluded. She is struggling with breathlessness, anxiety and some nausea, and is unsure how her partner and her will manage when she gets home. Referral to the hospice would be for symptom management, and as part of this could access our spiritual and psychological support and physiotherapy support with breathing exercises. We would facilitate planning around discharge with consideration of equipment and care, and onward referral to the appropriate community teams. End-of-life referrals are for patients that are in their last days of life and are considered to be end-of-life. These patients are often rapidly deteriorating, often daily. They may be bedbound or with decreased mobility, sleeping more of the time, struggling to swallow and often struggling with the increased burden of symptoms. If you recognise someone is dying and their PPD is the hospice, please refer them as soon as possible, as there can sometimes be a waiting list for beds which can delay things. An example of an end-of-life referral may be Amir, an elderly man admitted to hospital from home as he wasn't eating and drinking. He has a background of advanced dementia. After investigation, he's found to have no reversible causes for his deterioration. His family is struggling with his changing condition and don't feel able to continue to manage him now at the end of his life. He has become agitated at times, is mostly in bed and is extremely frail. He's referred to the hospice for end-of-life care as he is thought to be in his last days of life. He is bedbound, struggling to manage any oral intake or medicines, sleeping most of the time and has periods of agitation. He's deteriorating daily. He's admitted, and after careful conversations with his family, they start to understand and accept his situation and that he's in his final days. He deteriorates and requires medication for symptom support at end of life. The patient and the family also receive psychological and spiritual support from our team at the hospice and the local imam. So in summary, discharge to assess patients, are they medically optimised for discharge and awaiting care or placement? Are they ready to be discharged from the acute setting but don't have support in place for this yet? Symptom management patients, do they have specialist or complex palliative symptoms impacting on their quality of life? And for end of life patients, are they considered to be in their last days of life? Should you need any further information, it can be accessed by visiting our website www.springhill.org.uk or scanning the QR code on screen, or you can speak to a member of the team by calling 01706 649920, and if you ask to be put through to the ward, you will speak to one of the ward nursing staff or doctors.